Welcome back. Today, we're taking a deep dive into the metabolic side of acid-base imbalances. Metabolic acidosis is defined by a pH below 7.35 and a bicarbonate level below 22 milliequivalents per liter. This occurs when the body either loses too much base or accumulates too much acid internally. The most common cause is diabetic ketoacidosis, often seen in patients with type 1 diabetes. When the body can't use glucose for energy, it begins to break down fats at a dangerous rate. This fat metabolism releases acidic ketones into the blood, quickly dropping the body's pH. In DKA, blood glucose levels typically soar above 300 to 350 milligrams per deciliter. Similar fat breakdown occurs in severe malnutrition or extreme high-fat diets, producing excess ketones. Salicylate or aspirin overdose is another critical metabolic cause, as it directly generates excess acid. High doses of aspirin interfere with metabolism, leading to a significant buildup of metabolic acids. Now, let's look at the lower GI tract. Severe diarrhea is a major cause of metabolic acidosis. Intestinal secretions are naturally alkaline. Losing them rapidly leaves the body's environment acidic. Even heavy exercise can trigger a temporary metabolic shift toward acidosis. Under low oxygen conditions, muscles produce lactic acid, which enters the systemic circulation. Perhaps the most chronic cause is renal failure. When the kidneys fail, the balance is lost. The kidneys lose their ability to excrete hydrogen ions or reabsorb the bicarbonate the body needs. To compensate, the body uses the lungs. Watch for Kussmaul respirations. This deep, rapid breathing is the body's attempt to blow off CO2 and raise the pH back to normal. Patients may appear drowsy or dizzy. If untreated, metabolic acidosis can lead to a coma. Cardiovascular signs include hypotension and dangerous cardiac dysrhythmias. Always monitor the heart. Nursing care must target the cause. For DKA, we provide insulin and aggressive fluid resuscitation. For renal failure, dialysis is essential to clear metabolic waste and restore electrolyte balance. Dietary management includes low protein to reduce waste products and a high-calorie diet for energy. Now, let's switch focus to metabolic alkalosis, where pH rises above 7.45. This happens when the body loses too much acid or accumulates an excess of bicarbonate base. Diuretics are a common culprit, causing the kidneys to lose hydrogen and chloride through the urine. The upper GI tract is the next source. Frequent vomiting or NG suctioning can trigger alkalosis. Stomach acid is rich in hydrochloric acid. When it's lost, the body is left in an alkaline state. Hormonal imbalances like Cushing's or hyperaldosteronism also play a significant role. Excess aldosterone causes the body to retain sodium while flushing out potassium and hydrogen ions. Even massive blood transfusions can be a cause due to the citrate used in stored blood. In the body, this citrate converts into bicarbonate, which can push the pH into an alkaline range. Nursing assessment is critical. Closely monitor ABGs, potassium, and calcium levels. Administer prescribed medications and fluids to correct these dangerous electrolyte imbalances. Always stay vigilant for signs of tetany or cardiac changes as you treat the underlying cause. Whether it's acid gain or base loss, metabolic balance is a vital sign of health. Remember, assess your patient first, monitor those labs, and treat the specific underlying cause. From treating diarrhea to managing DKA and renal failure, your care makes all the difference. Keep those pH ranges top of mind, 7.35 to 7.45, that's the body's healthy tightrope. And remember your metabolic marker, bicarbonate, normally 22 to 28 milliequivalents per liter. We've covered a lot today. Take a moment to review these metabolic pathways one last time. With these tools, you're ready to provide exceptional care for patients with metabolic imbalances. Thanks for joining us. Keep learning and keep nursing. See you next time.